Hi, I'm Nick from OSP, and welcome to our live question and answer session. Uh, I'm with John, our Vice President of Technology from OSP. Uh, John, would you like to introduce me?
Sure. First of all, yeah, I'm here in overcast Santa Monica. So welcome. Nick is in New York City. So from coast to coast, we hope to answer all your questions today. So Nick has 47 years experience in advanced information technology, including 20 years in clinical solution, which range from bioinformatics, biomedical research, with application of machine learning for pharmaceutical, vaccine, infectious disease research, major clinical institution, as well as a high-tech major computer organization. So in my collaboration with Nick, what I've really enjoyed, he has both the industry experience and the healthcare and the science behind advanced technology, which we need today. My own experience, I've got 30 years experience in deploying advanced technologies, typically to transform businesses and make them more efficient and better for the employees, for their clients. And at OSP, as a VP of technology, I often lead conversation between our teams of experts, including Nick, and our clients in healthcare technology or healthcare services. And our clients are in both arenas. So there is a lot of very wide range of needs, which we're going to talk about today. Nick?
John, thank you. And so let me just start this off and say in our last webinar or our series of webinars, we spoke about different digital health technologies and strategies that were currently transforming the healthcare industry, as well as some of the current issues that have that became the catalyst for using digital technologies in support of telehealth like COVID-19. But with that said, uh, when I say transforming the healthcare industry, but also changing patient experiences and positively impacting patient outcomes. So many questions came up about digital health. So today we are here to start answering some of these questions. Thank you, John.
Sure. I mean, I just wanted to add, it's obvious to everyone, COVID-19 has really pushed us and really accelerated the movement towards technology adoption. And it's really highlighted the need and benefit and challenges of implementing digital health. I mean, patients want it more, they can be served from home. And of course, doctors now can spend their time more efficiently. So there is a need both from healthcare industry and general population. Their mindset has changed now and they understand the advantage of it. So of course, a government and other regulations have come to help us. Many changes, new regulations were introduced to solve the challenge and that traditional health system couldn't solve. So now we are moving to a new, more patient-centric innovation.
Yeah, absolutely, John. And so therefore this transformation will meet or has already met many new things, new learnings, new questions that are constantly being asked, and also leading to even more advanced innovations in the digital technology arena supporting clinical. So let's start our questions, John.
Yeah, so, and by the way, for everyone attending today, we're going to start with question that was sent to us, and then we're going to make sure to reserve time for additional question that you can post, and then we'll, as much as we can, we're gonna try to answer everything. So some of the obvious a question, the more general question, and then more detailed on the technical side is, we all know digital health is growing, and mobile health application are starting to replace traditional web-based system. Now, how can we help patients, but also healthcare staff to adapt?
Well, John, that's a very interesting and also critical question because based upon my experience, you may have the most advanced technology out there across different types of industries for different products, but without taking into account the customer or users of these systems and where you must mitigate such issues and provide training and insights into how to use the technology, as well as even to make the technology simple from their perspective without changing the underlying advanced technology. So how we could help patients as well as clinical staff is in our capability, meaning us technologists, to basically make the system simple from their perspective. In other words, let me give you an example, a user interface, say to enter certain patient data as the patient came into triage. We should not make the user interface so complicated where we're trying to make that nurse into a computer engineer, but rather it's simplified. The right questions are being asked in terms of what the nurse needs to be answered. And so therefore that is one way. And I would also take that same approach to consumers, patients, from a user interface / interaction, keep it simplified. Remember, particularly, and it's true for clinical staff, but more so for consumers / patients, because these technologies in digital health, specific to consumers / patients, are being used by different levels of patients, different types of patients, in terms of education, in terms of reasoning, etc. So it's very important, like we used to say at IBM, keep it simple. Keep it simple and to the point. So that's number one from the UI for both clinical staff as well as consumers / patients. The other way, the secondary approach is mitigated through online training. Like you see several YouTube videos that'll help immerse you into new technology, things like that. And going back to the digital health technologies that you do release, supplying some sort of intuitive wizard or some sort of help that's not elongated text, but it guides the person as a personal advisor, not necessarily a personal assistant, to get where they need to get and to use it. And so to me, there are two approaches. Thank you.
Yeah. And I would like to add, we often find that having the right dashboard for the right audience that is simplified to the maximum, so that it can be a different dashboard for the patient, for the doctors, for the nursing staff, and some of even the hospital administrator. They each need to have it simplified for them. And in a way, here's a second question we will ask is, how will automation help clinics who follow currently traditional paper-based systems?
Well, automation will help clinics reduce the cycle time it takes, like for instance, to get lab results back, particularly you take many clinical institutions, they will send people to labs for all sorts of testing, like the Quest Diagnostics or ACM is another one. So through integration and smart workflow automation, they could reduce the cycle time it takes to get the answers back, so doctors can then reduce the cycle time it takes to resolve a patient's problems. And so automation, you have to think of automation across all industries, but particularly clinical, as being smart. Let me use a term that we use in the computer industry, or orchestrated workflow, meaning orchestrated, meaning that it's smart. It's based upon business logic, and that drives the points of integration. And with that, also validation of responses coming back. But automation in itself, as I explained, will help reduce cycle times it takes to get the answers to the patient, get them to see the specialist that they need, and also help with billing issues, etc.
Okay. Now, before getting into more detailed question, one last one of a general nature. And there's so much to talk about, but let's keep it short for now. And there will be more. It's about the patient experience. We have seen to believe, and many professionals in the healthcare industry have agreed that as patient experience matters a whole lot. And it's going to make this whole process work better. Can you tell us more about your own experience, Nick?
Oh, yes, absolutely. It wasn't until 1999 when I was working for Lockheed Martin that we had secured a major account, and I was the chief architect, systems architect for the national healthcare system or service in Britain. And the major focus was implementing customer relationship management, not just the software, but best practices and so on. So I remember, because this was an eye opener, uh, being put forth by their representatives in the National Healthcare Service that we see patients as consumers, as customers. So therefore, we need to not only have the establishment of good relations, but we also need to be proactive in a data mine. This is where analytics comes in, to data mine what in fact types of services, how can we expedite and predict or try to be on the forefront of providing these services. This in itself will add to a very welcomed and satisfying patient experience. And so that was an eye opener, because in the States, patients were patients. If you said consumers or slash customers, that used to leave question marks. Well, what are you trying to convey? And last thing about patient experience, you have to take that also into now with digital health technologies, mobile applications. Again, everything goes back to the user interface and the functionality that's architected and designed underneath that user interface has to be very technologically advanced and complex, while ensuring that the user interface is simple and it's to the point. So that addresses user experience.
That's right. Absolutely. I mean, I can share myself as a patient. I've been going to the same office of doctors in Santa Monica. And with the advent of large organization just buying out a whole bunch of practices and then implementing digitization, maybe in a way that was not always the best in the beginning, it's made me want to look for new providers. So really the providers who really pay attention to how to interact with the patients are really going to have an advantage in this new world. So let's get into some more technical questions we were given by some of you. The first one is, what are all the different scenarios to be used to get patient documents via nominal or alternate flow?
Okay. Well, thank you. And the use cases, when we speak of, well, scenarios, I'm using the term use cases, nominal versus alternate, you could apply that to any industry. So basically what we're talking about, if then else logic or Boolean logic. But the first one, well, let me start with alternate. So the scenario slash use cases to retrieve patient documents by an alternative flow refers to an optional flow that that allows the documents to be obtained by secondary source. For example, a governmental request. For example, if you were to basically make, say, a relative or close friend as a person who could obtain your health records when you could not for whatever reason. So in this case, there are no privacy consent directives for the patient, as well as only the organizational. Again, you're under the clinical organizational rules, as well as jurisdiction, meaning state, local, state, and federal laws. The next one, nominal, refers to patient documents by a normal flow, which is what? Copies of your medical records requested for any other reason by you or someone who you've authorized to have access to your medical records or any other supporting documentation. So that's the difference between nominal versus alternate flow.
Okay. Another question. This is a bit technical, but hopefully some of you will find it relevant. What is the use of an asynchronous request in the ITI 55, ITI 38, and ITI 39 standards?
Okay, John, thank you. And as you know, I gave you a write-up, so I will pick specific answers to answer these questions without getting into the technical aspects. So when we speak of these standards, we're talking about the NHIN Patient Discovery Web Service Interface Specification, which was adopted by the Cross Gateway Patient Discovery Transaction, which is ITI-55, is the protocol, the network protocol for patient discovery. So these modes and their expected use, for example, you have demographic query and feed. You have where both the demographics and patient identifier used by the initiating NHIO are included in the request. The second one would be only the demographics of the patient are included in the request, and the initiating NHIO does not have or does not specify patient identifier. So that's the secondary view of this standard ITI 55-55. And then the third one is there's shared a national patient identifier query / feed. Only a shared / national identifier specified in the request. So use of this mode will be deferred until until a clear use case is presented. So again, this was somewhat technical, so that answers the question ITI-55. Let's go to ITI-36, and keep in mind, this is, quote, we're talking about the Patient Discovery Web Service Interface Specification that was adopted by, again, Cross Gateway Patient Discovery Transaction, ITI-55. Now for ITI-38, it's a cross gateway query, quote, find documents request to the responding gateway to a query for document entries for the patient. I'll leave it as that. Again, we're getting into network engineering relative to the standards for the clinical community. Last one, initiating gateway sends a IEH cross gateway retrieve. That's a message according to standard ITI-39 request to the responding gateway to retrieve documents. The request includes the document, the repository, community IDs at the responding gateway. Let me give you an example for the last one. Those that use Epic know that as their EMR / EHR system, they have a clearinghouse where Epic-like customers can share HL7 records and other pertinent medical records. Then there are, like, for instance, open clearinghouses like the Sequoia project. And so the third one basically suits that sort of scenario. John, forgive me for being too technical.
And certainly if some people want to know more, we can forward information or links to where you can find further information for yourself. Another question was, how does authentication work between two different implementers to exchange patient data?
Okay. Let me read this and then I'll give an example. So digital authentication is the process of determining the validity of one or more authenticated users to claim a digital identity relative to the medical records being sought after between one or more entities. For example, a clinic, insurer, governmental, etc. So let me take a step back, okay? So authentication in the IT world, that conjures up LDAP capability. LDAP is a technology whereby it will authenticate. Nick Bucciarelli is currently employed full-time by Clinical Institution X. Nick's role is a bioinformatics scientist, data scientist, etc. Now, if I'm dealing with, say, another clinical institution, what would be set up is a hybrid of a LDAP capability. In other words, you would have, I would give that second clinic access to an LDAP capability that was outside my firewall that had my credentials and other people, meaning outside the firewall. So this other implementer could not get behind the firewall, but on the production side, and vice versa on his or her side. So that's how I would deploy authentication in order to have access to records. Thank you, John.
Sure. Now, the next one, I know the answer is fairly complex and comes with schematics. So I'm not sure if you want to talk about it, maybe we can send it to people interested. But that question was, what should be the application architecture to manage multiple initiating or responding gateway for each home community ID?
Okay, and yes, we can post a series of models for your own reference, but let me just start this off and say, this information is available through government and through academia and through major clinical institutions that usually have research arms, or it's a teaching hospital, and there's standards out there. And so I'm referencing the IHE IT Infrastructure Technical Framework Supplement. For example, cross-community document reliable interchange. So when we talk about community A being clinical 1, community B being clinical 2, community C being clinical 3, three separate entities, we're talking about establishing a federated network architecture whereby through that infrastructure and deploying gateways and of course reverse proxies outside of their firewalls, I can communicate. And what I'm thinking about is the federated communities with XCA process flow diagram. We could get very technical, but again, there are standards out there, very detailed, not conceptual, that you would have a starting point to basically define what your federated architecture would be, your federated network architecture would be, as well as you may have federated applications, data repositories. So I'd just like to mention that I have a paragraph, but again, we could post the standard and we could post my write-up to that standard. Thank you, John.
Yeah. We will do this on our website. Here's another question. What are all the possible ways for home care service providers, agencies, to verify caregiver visit hours before submitting the claims to clearinghouses?
Okay. Well, the industry has historically been dependent on each payer's specific paper claim format. Today, electronic billing, I would refer to it as e-commerce, is more standardized among payers, with many agencies now billing using the 837P or 837I electronic data interchange EDI. So electronic data interchange, they're not leveraging the internet like e-commerce would with EBXML. They basically have an established private network using EDI, electronic data interchange, where you have this concept of evaluated networks being set up, at multiple sites. And so claims are submitted earlier through a clearinghouse. So these clinical institutions that have an EDI infrastructure internally have a clearinghouse outside of their firewalls in order to exchange payment, billing information, where then can be consumed by clinical institution one as it hits their reverse proxy and is accepted and processed through their EDI claim forms network. So although the industry is still dealing with the lack of across-the-board interoperability, keyword in clinical, there should be greater efficiencies and once state aggregators of Medicaid data come online. So many states providing Medicaid services use data aggregators that collect verified visit data from home care providers or claims processing. So I will stop there, but add one more key point. Everyone knows about HL7 messages, and everybody knows that on an average basis, a clinical institution may receive up to 5 to 7 or 8 million a week. And so you take like the state of New York. The state of New York is divided into 6 private regional bodies that share these HL7 messages. And then there's a state body, but then there's a federal body called FEPS. So if you multiply that by 49 other states, and I believe even the Canadian provinces, you have a lot of traffic. That's why we have these clearinghouses. And that's why I believe they use a proprietary network approach, call it e-commerce for billing, which is electronic data interchange. It's been around since the 70s. Thank you, John.
So here's a simple, and thank you, Nick. Here's a fairly simple question. How to manage the claim for patients who have more than one insurance active on the same service date?
Okay, well, under the coordination of benefits in many group plans, your secondary insurer can cover what your primary insurer does not. So basically, like in the case of my wife and I, our vision plan, believe we have VCP. So that's our primary. And if it's $300 per visit, there may be $25 left over. So then my wife's secondary insurance would kick in and cover that. So basically that is what it's stating. That needs to be set up with the vendors. And of course you have to ensure the vendors are within network or not. So to close this out, often benefits are only covered up to a certain percentage and up to a max amount per year. Again, it depends upon your provider. That also depends upon the vendor that you're dealing with that deals with your provider, which is the insurance company. So basically with 2 plans, you can end up recouping 100% of your out-of-pocket. And I know my wife and I have been very successful like other couples. Thank you.
Thanks. What is Cures Act 2021? What point does it cover from a data handling point of view?
Okay, well, I have 2 quick bullets. The 21st Century Cures Act, that's exactly what it is, besides its acronym. It was signed into law December 13, 2016. Is designed to help accelerate medical product development and bring new innovations and advances to patients who need them faster and more efficiently. So when you look at this and you look how negative scenarios like COVID-19 has basically exponentially moved digital health and new innovative technologies into the limelight, this law does help. It also helps with the fact that a year ago, President Trump signed a bill, or was it an executive order? I can't remember. That basically it says, I believe it was coined the right to try. So if you have a terminal disease, you have a right to try even an experimental drug or treatment. And so this law helps, this act rather has helped set the precedent. And the last point I'd like to make, rules mark the most extensive healthcare data sharing with ability to manage their healthcare the same way they manage their finances, travel, and health information networks. So basically, when you look at this, this act also expedited the sharing of healthcare records quicker, faster. That's why you have many clearinghouses. That's why going to the scenario that I just stated about New York State. And so this 20th century, this 21st Century Cures Act has been the catalyst for many changes supported by these negative occurrences like COVID-19.
Thanks, Nick. Uh, Now, what are the different ways that can be employed to recover balance payment from patients?
Okay.
And
Well,
this is
first of
becoming a challenge for many, many practices and hospitals, and of course, uh,
Mhm.
from the patient's point of view, sometimes the billing is so complicated, they don't even know what they owe to whom, or they might contest and go, what the heck am I paying? And why am I paying it? Too often the information is missing.
Mhm. Exactly. Exactly. And too often there's been mistakes in billing. Oh, I paid this, but I received the same bill. So to answer that, one, use appointment reminders to prompt bill payment. So if you have an appointment up and coming, and say you owe a balance from whatever services provided before by your clinic, uh, you may receive a prompt in your appointment. For instance, uh, for instance, Guthrie, who's my provider in upstate New York, would send me a text message. Hey, Nick, you have an appointment 2 days from now. And in it, you can include, oh, by the way, don't forget about this remaining balance, just to give you an example. Second one is be transparent with patients about prices. This coincides with what President Trump had stated, that clinical facilities, medical facilities should publish what their prices are. So you're not paying $200 per aspirin. They should publish that. This would make clinical institutions more financially efficient or solve it, but this would also help our patients, our consumers. Third one is purchase a billing management software system. This is what several clinical institutions, a small minority, particularly if they're smaller, like in rural, semi-rural areas, they represent a bona fide billing management software system that would have the accountability, maybe age bills every 30 days to say, hey, okay, it's 31 days. We seem to send, we need to send another notice out. So it's having the right billing management software system. And in many cases, if your EMR or EHR system, whatever term you want to use, does not support a robust billing management system, it's okay to look at a third party. Matter of fact, I highly suggest that. The fourth one is collect payments. Um, Give patients the capability to submit through a secured portal, HTTPS. Next one, give patients the benefit of the doubt. In other words, do not assume that they're trying to escape payment. At the same time, it's your responsibility to remind them and keep reminding them in a consistent but proper and respectful manner. Know when to use a collection agency. That's always tough. It's up to what the CFO for the clinical agency would basically set in place. So it goes back to business rules. Yes, collection agencies are good, but keep in mind they keep a certain percentage. Uh, I've seen many clinical institutions, particularly where they have like urgent care and these off-site 7 by 24 locations. Um, uh, they basically they will offer payment plans. Even clinical institutions without these off-site facilities do offer payment plans. Uh, Last one is train staff to prompt for payment. Well, what does that mean? Uh, when you go for your appointment, when you arrive for your appointment, rather, and the first thing they say, oh, you have a copayment of $20 or $30, right? If in fact there is an overdue balance, in a politically correct but sensitive way, remind them and also direct them. Well, maybe you should consider this payment plan that we have, considering your circumstances. I mean, when you look at people who've been laid off, they've lost their jobs or health insurance due to COVID, I think it's the right thing to do. Thank you, John.
Thank you. Thank you. This was very thoughtful. It's important, of course, because after all, there's business to be run, there's staff to pay, and it's important to get payment, as well as being sensitive to patient. At the same time, you need to keep your business going so you can serve more public. Here's an interesting question. How do you integrate with Labor America and Quest to get patient lab information?
Okay. Well, Quest, they were referring to Quest Diagnostics. Let me just say this. So this question is very specific to get patient lab information. Well, first of all, there's proprietary electronic data interchange capabilities where I'm not leveraging the internet. It's a point to point. I have my own infrastructure set up in order to facilitate the integration of patient information, lab information rather. Then there's also client maintained FTP server with FTP software. But if you're going to do this, make sure you use SSL secure socket layer and make sure you use encrypted keys. The other point, if secure protocols are not used, data files must be encrypted. Let me make a very, very critical point. Layers of security. You can't do enough in terms of layers of security. When you consider the SQL injection attacks, now we're in the cloud and I'm supposed to deploy neural networks on reverse proxies to trap these intrusions, like with SQL injection attacks. Not only should you use protocols, secure protocols like secure socket layer, but you should always, always encrypt the data. The data should be encrypted. A matter of fact, make sure you have for example, there's decryption software, there's the S-MIME security certificate or public key, but never take either one. And if you have your own proprietary infrastructure for communicating lab information back and forth, meaning you have electronic data interchange, lock that down too. So that's my word of wisdom for 9, because I had lived this and I had many stories to say, but it's not time now. John?
Well, thank you, Nick. We're trying to keep our answers short so that we can get to questions that are coming in. Here's another one. How do you integrate with CVS to get patient pharmacy information?
Well, as you know, there's standard industry protocols. Let's take a look. There is the internet. Well, what do I mean by the internet? You have open APIs that can be exposed. I know with CVS, which they own Aetna, an insurance company, they basically have many cloud deployments, public cloud deployments. And you could deploy a REST API to do a call to any open API that they expose for patients or for vendors, etc. So that's one thing. Then there's the traditional middleware technology. There's microservices. Uh, this is pretty much, it's out there. It's out there for integration and quote interoperability. And then also, last thing, when you look at deploying integrated networks externally while leveraging the internet between, say, your clinical facility with multiple sites, uh, these standards come in very handy. Also using service buses like Rhapsody used in medical prior Mirth, and also ensuring it's integrated to like a patient index capability similar to an LDAP. I'm thinking of IBM's EMPI capability for identifying patients. Thanks, Sean.
Sure. So there is another question, and then we'll jump quickly to Q&A. Uh, what kind of ability do company have, including us, when we speak to different clients and they have needs for example, for wearable devices? Wearable devices are going to be used more and more, and they're going to require other kind of readings to be acquired while the wearer is active, and then aggregated with disparate data coming from different places to then start making sense of what's happening in a room where they are. And so how do we work with them to do research and to then apply AI machine learning to predict certain events
Hmm.
based on aggregated data? Because now we have data that can come from so many places, and how
Hmm.
best use of it, and it could be complex.
Well, okay, and I'll try to answer it within 2 minutes. I could do a whole lecture on this, but let me cut right to the chase. What we at OSP provide is foremost, as we talk about alphanumeric data and multivariant type of content. I use that term to describe static, dynamic documents, images, like from radiology. So that's why it's a multivariant quote content. Of course, there's alphanumeric. Um, and now with all the digital capabilities to remotely gather data from customers, and to share it via mobile applications, the first thing we do at OSP is emphasize a enterprise architecture. And a key part of that is the digital enterprise architecture subset of that, which equates to what? Internet of Things. Because not only do I have these remote devices, but I need to integrate with my infrastructure, whether it's in the cloud or on premise or both. So, where AI comes in very heavily is by deploying, by using this architecture, the digital architecture enterprise, which is a subset of the overall organizational enterprise architecture. I am looking to see for the establishment of computational clusters where I could segregate like alphanumeric data and multivariant type of content by maybe a specific category. Like in clinical, there's 14 medical domains. And then from there, I could use MapReduce and distill my rules, let's say, for understanding the information. But instead of having it be rules driven, having the deep learning algorithms, not machine learning algorithms, but I'm talking about machine deep learning algorithms that will mine, that will do analysis, that will look at the combinations. Let's take medications as one of the 14 clinical domains. It will look for certain commonalities in relationships between a specific medication and the byproducts of providing this medication, as well as related symptoms if I use another medication, etc. So machine learning has many different capabilities. And for myself, using it in biomedical research, um, it has been very helpful in terms of developing uh, predictive models and doing causal analysis before a quote problem happens. This is when I developed the root cause, pattern or of classification for a specific problem, which I've identified the root cause. But now I have one or more other patterns of self-remediation, meaning correction. And so the data, the alphanumeric data and its related multivariate type of content per computational cluster, it's constantly metamorphosizing, thinking. It's critical reasoning, the analytical ability. So basically what I'm saying is cognitive ability, those two, to think, not just store and interpret, but now create new insights for you. And the more humans that it interacts with, your analytical engines, the more powerful its capability as a human brain to think. And in this case, we're talking about recurrent neural networks, even though there's other neural networks. So
Thanks, Nick. This is a big project, of course. And if any of you have any further question, please send this to us. And if we cannot address it now, you can always contact us for a one-on-one conversation between our teams. But let me for now, and of course, AI machine learning can be applied to different use, whether it's mobile devices, information coming from different places, can also be applied to billing systems and practice management systems and on and on. So let me start sharing some question. Here's the first one. There will be a lot, so we can start answering quickly, and obviously some of them will require more follow-up. So here's someone who says, we are an audio video integration company and we build conference rooms. One of the ways we have responded to the pandemic is we've rolled out touch-free conferencing. So what are some of the other COVID-influenced technology in healthcare? And we hear of so many, but any thought how to answer this, Nick?
Let me just take a look at that one. Build our conference, one of the ways we have responded.
Well, COVID-19 new technology.
Rolled out the touch-free, yep. What are some of the COVID-19 influenced technology is now in healthcare? That is a little, let me answer it this way. So in the same way we're using video conferencing, your question is, what are some of the technologies that are being used in light of what we're facing, which is this pandemic? And it would be also the ability to whiteboard between physicians. They're working on a specific problem. Also the ability to share labs, radiology, also having the ability to have mobile applications that can be touch-free through natural language processing. That question is a loaded question.
Sure.
And the way to answer,
I just would like to add, it's so wide. There is a webinar we did recently about remote patient monitoring. That's also a huge area, and a lot of details were shared on different kind of tools and things that are possible to reach into senior homes, home care, remote patient monitoring. And these are a lot of different ways in which there is more safety also for the patient. Not only do they get care remotely or healthcare workers or doctors can be alerted if there is a problem, but also they don't have to get on the bus, to get in a car, wait in line for hours to see someone. There is so much that is being done. So as a follow-up, we're going to repost a couple of webinars we had where we address this topic with all kinds of technology that is coming out. We have a lot of creativity at play right now that's going to be really, really helpful, not just for COVID-19, but going forward for patient care in a much more thoughtful and powerful way.
Yeah, and sorry. No,
I was have a lot of questions, but yeah, go ahead. Sorry.
Sure. I was going to add onto this. If you're working with a client of yours, I go back to enterprise architecture in the digital enterprise architecture, critical subset, particularly when we talk of Internet of Things. This way you could identify and know exactly what needs to be integrated and what value they have. John?
Yeah, well, there is a related question, which is a good one. With all the data in the cloud today and digital health application, telehealth, remote patient monitoring devices, wearable devices, does that pose a risk to data privacy and leaks? And we know it does. And then the second part of the question is, you mentioned encryption is key. Is there a possibility to keep our data 100% safe?
Well, okay. To answer your question, let me start with the latter part. Yes, 100% safe. Or let me say 99.9 okay? Because as much as people like us get smarter, the criminal part also gets smarter to keep pace. But encryption is very critical. Let me also give you just a very, please, John, cut me off if I elongate after 1 minute. But basically, in a clinical institution, what I've advised them to do is to set up in their DMZ access public zone a set of reverse proxies. And on these, they would be clustered with a reoccurrent series of neural networks. And so from the DMZ public access zone, then you drop back to the DMZ access private zone. Same thing. Set of reverse proxies, set up a reoccurrent artificial neural network. Now, if a SQL injection attack is able to penetrate the DMZ access public zone and get into the private zone, you have two fallbacks because there's these, quote, smart firewalls built on neural networks that will not only capture it and attempt to interpret it, develop a anti-pattern of resolution when it sees certain patterns. Think of like cryptography. And but notice how two layers, DMZ access public and DMZ access private zone. Now you drop behind the firewall, either your production as well as non-production systems. You set up a series of reverse proxies again at each layer, the UI layer, business tier layer, application layer, and data layer, because you want fallback. You want to trap. So if it bypasses, you're going to have another way of trapping it. So yes, 100% secure. Now, in the cloud, when you say you have two cloud provider, client with two separate cloud providers, that same approach is taken as well. So yes, I would say
Sure.
99.9, okay? And the other part, with all the data in cloud, is digital health applications like telehealth? The answer is yes. Remote patient monitoring devices like wearables pose, okay, it doesn't pose a risk to data privacy and leaks. Why? Because the technology is so advanced. If you remember when the FBI was trying to order Apple to please give me that encryption, that embedded software, they said no. And so again, advances in technology and the cloud itself also takes a very serious emphasis, more and more so, on security and network protocols. Thank you.
And of course, the obvious is whatever devices you decide to implement, you need to confirm what kind of security that they are providing and that they fit in within your own architecture. I see another question here about cash pay, like health plans that eliminate the prospect of a balance bill. Apparently, there is a lot of new self-insured plans that treat patients in network and out of network doctors the same. And there is an emerging use of cash payment for care. And it's using HRAs, healthcare reimbursement account, so that consumer portability of health plans will be more possible. I'm not sure how much you know about this topic.
Oh, yes. Well, you take a look at healthcare, the HRAs, healthcare reimbursement accounts. Most people have them, particularly if you have a family. I know when my children were young, my wife would put away X number of dollars per year, but you had to use it by the end of the year or the state would take the money. Okay. So now we're talking about, well, what about cash payments? Okay. Yes, you could use cash payments to pay a provider, but that money, as long as you had the receipt, that receipt can be applied against the certain the exact amount that you have in your reimbursement in your HRA. So I don't see a problem with cash payments
Okay.
whatsoever to providers.
Now, if anybody has question, the most efficient way, there is a Q&A tab at the bottom of the Zoom the video, and if you click on it, you can enter your question there. If you entered your question in a different way, is that something you can check, Nick?
Yes, we only have, oh wait, we have another one that came in.
Okay.
Brian Smith, do you think digital health will grow and patients will adapt to it? And oh, yes, yes. A matter of fact, let me make this clear and concise point. Let's take baby boomers, which I'm a baby boomer. About maybe 50 to 60% of us are computer savvy. You know, we've been in the field, we grew up with IBM and so on. But a vast majority, about 90%, are better equipped to use digital technologies than the X generation and even the millennial generation. And what I mean by using these different systems are that we understand that if the push button doesn't work, okay, we understand critically how to troubleshoot at a high level instead of just, oh, wait, this application doesn't work, okay? That's not to say that the younger generations after the baby boomers do not, but it's being adopted. Digital health and its ability to reach rural communities. It's why telehealth has grown so much. And of course, COVID-19 and other factors like Obamacare has really moved this whole concept of telehealth to help diagnose patients, to help prescribe, to establish relationships, not only for the medical area, but the medical arena for medical treatment. But when you look at the devastating effect of COVID-19 on the economics and the amount of depression that many people are going through with losing of their livelihoods and so on, that whole area of medicine
Mental health.
mental health has been lifted very heavily to help people who need help. Again, particularly in those rural areas, because since Obamacare, many institutions, be it bad, good, or indifferent, they've consolidated. They're like conglomerates right now. And many local hospitals closed. Many practitioners retired or became part of a big conglomerate. So it has shrunk. So then also moved telehealth and other ways, like for instance, when you need contact lenses or medication, you could get that through the US mail, whatever, or carrier. So.
Mhm, mhm. Yeah, I've experienced that living even in a big city, the outskirts of Los Angeles, Santa Monica. I found that even large institutions, have cut back on staff. They have to be more efficient because the cost of some of the things that they've had to do is so much. In any case, the time is up. We thank you very much for joining us today. We try to answer as many questions as possible. We're going to do this again, so please feel free to check our website, osplabs.com, to learn more about not just us, but also we provide information on what the healthcare industry is doing as a whole. And certainly feel free to subscribe to receive updates and invitation to other webinars we plan to have. So again, thank you very much, Nick. Thank you to everyone who attended, especially those who sent us questions. And we look forward to collaborating and communicating more now and in the future. So thank you very much.
Thank you.
All right. Thank you, Nick.
Take care.
Bye.
Bye.